I've been working on composite tests, composite outcomes for, I think, about 14, 15 years now. And the goal of those composite outcomes, the ones that I've been involved in deriving, the goal of them is to actually identify the most progressive aspects of disease. And what that means is you're identifying the core features of the disease that are actually changing over time. For instance, some symptoms may sort of come and go at different times, and things like behavioral aspects of disease, anxiety or depression, can be things that come and go and are sort of episodic. But things like cognition really are progressively worse over time. So you see people just adding on to how to their symptomatology in those areas. So they're slowly losing the ability to perform cognitively as time is going on. And so because of that continued progressive loss, what you want to do, the best way to measure these diseases, is to actually put all of the most progressive aspects together into one overall score. And what that means is, with degenerative diseases, there is a gold standard of progression. And this is also consistent with the time aspect that I talked about, because in a degenerative disease, time is the most important aspect. And I sometimes talk about time as a gold standard, that the gold standard is time. Any aspect of the disease that's not progressive kind of doesn't matter as much, because if you can slow down the progressive aspects, then the episodic pieces will take care of themselves. And so these composites have been meant to target the most progressive aspects of disease, so that when you then measure progression, you can see a treatment difference against that progression. And that treatment difference is more likely to be aligned with disease modification. Now, there are several outcomes that have been designed specifically for progression. We derived the APCC, and there was also an API load scale, and those were both around 2010, 2012. And both of those scales were specifically derived for progression. There are a lot of other scales that have been derived, and those are both cognitive only, very early AD, and even pre-MCI stage. The PAC scale was derived specifically to separate groups in terms of those with amyloid and those without amyloid. And that's a different goal, but then it's also been used progressively. And it may or may not be as good at detecting those longitudinal changes, because it wasn't really originally designed to do that. And there are also several scales out there that are clinically proposed and are decided on the basis of what people see clinically. And that, again, may not target the most progressive aspects of the disease. So the composites that we've advocated for in a mild cognitive impaired stage or an early AD stage now would be ADCOMS. And ADCOMS was one, again, that was derived specifically for progression and was used in the lecanemab BAN 2401 phase 2 study. And again, in that study, it did what it needed to, which is to really measure progression very efficiently, so that when you saw a slowing of that progression, you could detect it. So this approach is complementary to the approach of using time as your outcome measure, talking about how much time is saved, because these outcome measures are targeted to be as close to linearly progressing over time as you can get it. And by doing that, it sort of ends up being a surrogate for time. And as I mentioned, I believe time is really the gold standard we should be focusing around.